I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the AIDS epidemic from the very first cases in the early 1980s to the current era of one-pill-a-day therapies, a triumph rarely equaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases of AIDS and their myriad manifestations. Hence the idea of these videos. They feature a series of images illustrating one or several exemplary case studies, mostly drawn from my files. Mrs. B was a 40-ish housewife with pneumonia and oral candidiasis. She didn't respond to treatment, and a bronchoalveolar lavage revealed Pneumocystis on July 18, 1982. That's when my colleague Daniel Lev likened her case to those recently described in Homosexual Men in the United States. Despite high-dose cotrimoxazole, she progressed to ARDS and died. We never found out how she was infected, possibly in Haiti in 1977 because she had hepatitis B, another infection transmitted by sex or blood, after she returned to Geneva. Thus, AIDS was first diagnosed in Geneva in July 1982. In retrospect, however, there was this man from Kinshasa, Congo, transferred to Geneva with suspected tuberculosis, who died in December 1980 from cryptococcal meningitis. At autopsy, no TB was found. The lung lesions were due to generalized Kaposi's sarcoma, which was also found in the lymph nodes and the duodenum. 6 months before the famous report in the Morbidity and Mortality Weekly Report, Volume 30, page 250, June 5th, 1981. Back to Pneumocystis pneumonia. By the way, is it Pneumocystis carinii or Pneumocystis Jirovec? The disease was originally called Pneumocystis carinii pneumonia, but the parasite called carinii actually infects only rats. The human parasite is Pneumocystis jiroveci, named after Otto Jirovec, a professor of parasitology in Prague. Nonetheless, the acronym PCP continues to be used. With this bit of trivia out of the way, here are some images from a patient with moderately severe PCP. Increased interstitial markings are evident. In another context, one might think of left heart failure. There are also ground glass changes, particularly evident in the CT scan. This is an enlarged view of the previous patient's chest X-ray. Massive ground glass changes during progression to the adult respiratory distress syndrome, ARDS. Worsening after the start of treatment. This 39-year-old man presented with fever and dyspnea, The diagnosis of PCP was established on October 24 and treatment with cotrimoxazole started. The X-ray on October 26 is clearly worse. On October 26, prednisone at 1 mg per kilogram per day was added. 2 weeks later, the patient was much improved. Right image, November 6. Another example of transitory worsening after start of treatment on July 30th. On August 3rd, steroids were added. Improvement is evident 3 days later. Experiences of this kind led to the routine use of cotrimoxazole and prednisone for PCP. A patchy area of consolidation, particularly well visible in the CT scan. Also, note hilar lymph node enlargement, which is quite typical for PCP, but can also be present in other types of pneumonia. Most patients with PCP are severely immunosuppressed, with CD4 counts way below 200. Exceptionally, however, PCP can occur in patients with near normal CD4 counts, as in this man who had more than 500 CD4 cells per microliter at diagnosis. Pneumocystis, the pneumo referring to the lung, is obvious, but where are the cysts? They are not usually recognizable in plain radiographs. Here is an exceptional case where honeycombing is seen in the chest X-ray and extensive pneumocele formation in the CT scan. An HIV positive IV drug user with a CD4 count of 6 per microliter with cough, fever and dyspnea on December 3rd. Infiltrates predominating in the upper lung fields are more marked on the left. Brusque right-sided chest pain and increase in dyspnea on December 12th with right-sided pneumothorax. A chest tube is placed. CT showing bullae in both lung apexes. When one of these bursts, a pneumothorax may result. Autopsy preparation with many small and one large thin-walled bulla. In 1983, this elderly patient was infected by a blood transfusion during an aortocoronary bypass operation. He presented in 1992 with fever and a left-sided pleural effusion. Very unusually, the diagnosis of PCP was established by examination of the pleural fluid. Note massive bullae in the CT scan on the right, which are invisible in the PA chest film on the left. PCP can cause structural damage. After successful treatment, this patient was still dyspneic and oxygen dependent on December 12, 1994, 2 months after the diagnosis of PCP. However, improvement was evident 4 months later in April 1995. This patient had a first episode of PCP in 1987. He was then treated with monthly inhalations of Pentamidine for secondary prevention. In January 1990, he presented with fever and cough. BAL showed Pneumocystis. Note infiltrate in upper lung fields where pentamidine inhalations do not penetrate well. After treatment with cotrimoxazole, the chest X-ray was normal 4 months later. Immunosuppressed patients often have several opportunistic diseases simultaneously. Here is an example. A patient with extensive cutaneous Kaposi sarcoma presented with PCP on August 24, 1984. After treatment, the chest X-ray is much improved 12 days later. Note, however, the persistent massive hilar lymphadenopathy. The enlarged lymph nodes were due to pulmonary Kaposi sarcoma, which progressed during the next 6 weeks. PCP is also one of the more frequent opportunistic infections in children with AIDS. A 45-day-old baby born of an HIV-infected mother and a father who died of tuberculosis was admitted for cough and fever. The chest X-ray shows perihilar infiltrates, bronchial aspirate with numerous acid-fast bacteria, and culture revealed Mycobacterium tuberculosis. The patient was treated for TB and initially responded. However, at 5 months of age, he again had fever and cough with diffuse pulmonary infiltrates. He rapidly developed respiratory failure and died. At autopsy, a foamy infiltrate filled the alveoli, left HE stain. Silver staining revealed numerous Pneumocystis Jiroveci, right. I'll finish with a few images on diagnosis and pathology. This slide is from Mrs. B, the first case of AIDS in Geneva from 1982, which we met at the start of this video. The alveoli are filled with a spomy exudate. Special stains, here the classical silver impregnation stain, reveal masses of Pneumocystis. In addition to the spomy exudate, inflammatory cells and red blood cells fill the alveoli. The Pneumocystis are not visible with routine staining. There are many ways to color a pneumocyst. Some are shown here. There are several methods for amplifying Pneumocystis genes for diagnosis. Gene amplification is more sensitive than direct staining, with the disadvantage of detecting carriers, false positives. Therefore, gene amplification is often more useful for excluding PCP when amplification is negative. In this example, amplification yielded a 550 BP band during the first amplification and a 346 base pair band during the second nested amplification. The S lane is a standard molecular ladder. Thank you for watching. I'd be grateful for any feedback. This video is part of a series on opportunistic diseases in HIV/AIDS. Please subscribe.